and welcome to our evidence-based practices in schizophrenia care training. This is the second part of a three-part series on schizophrenia spectrum disorders and evidence-based care, specifically designed for volunteer supporters and other natural supports that are helping an individual go through the care process and better understand schizophrenia and the evidence-based practices and treatment options. And then the third part will focus on how can people provide support to individuals diagnosed with schizophrenia who are going through the care process. So today we are joined by three speakers that all have a really broad depth of experience with individuals with serious mental illness and all have different perspectives. So we have Deborah Rose with HMA, Health Management Associates, along with Mark Avery, a clinical psychiatrist with Health Management Associates. And we're excited to be joined by Dave Leone, who is a social worker, has been working in this space and is a co-executive director of Painted Brain. And they will get more into their background and their experience with individuals living with schizophrenia and how that impacts evidence-based practices. So let's look at some of our learning objectives today. Our goal is that by the end of this session, you will have an increased ability to describe principles of taking a person-centered approach and to really consider the whole needs and the whole picture of a person and not just a diagnosis. Also identify important aspects of evidence-based practices, and there's a range of different treatment options for individuals with schizophrenia, and we'll talk through those later on today. And then also there will be you should have an increased ability to understand the role of medication in a treatment plan. So medication isn't the only part of somebody's care plan, but it is an important part. And we'll have a discussion today about what that looks like. So on the next slide, we'll just go over what we're going to be talking about today and some of those evidence-based practices. So like I mentioned, we'll first discuss what taking a person-centered approach looks like and what that means. And then we'll introduce some evidence-based practices and models of care, including some specific information about an assertive community treatment, which is often abbreviated to ACT, and how that can be helpful for individuals with schizophrenia. And then, like I said, we'll have a high-level discussion about medications, including considerations, the specific role of the CARE Act, and then promoting adherence and how we can do that as supporters. So with that, I'd like to turn the time over to my colleagues. Mark, do you want to start us off?
Yes. Thank you, Patricia. And as Patricia mentioned, I'm Mark Avery. I'm a psychiatrist, and I've had the privilege of serving many hundreds of persons over the years who have experienced schizophrenia and schizophrenia spectrum disorders. And I've provided, most of my work has been in the outpatient and community setting, but I've done quite a bit of inpatient work as well. As you'll hear near the end, I also have done quite a bit of work in providing and prescribing psychiatric medications to folks. So I'll be talking a little bit about that. In part one of this series, we talked about symptoms and presentation of schizophrenia spectrum conditions. Now we're going to pivot to how we can be helpful. And the good news is that we have many evidence-based practices and things that we can do to help persons with schizophrenia, and that everybody has that experiences schizophrenia has the opportunity to have recovery and to be able to go on and lead more meaningful and successful lives. The goal of this section is to familiarize you with some of those evidence-based and promising practices that are available so that you're able to support people who may be receiving those services. And just a note here that for those of you listening in here, that we're going to be referring to supporters throughout this training. And this is in reference to those individuals that provide support to care program recipients, including volunteer supporters, family members, friends, neighbors, colleagues, and that sort of thing. And like part one, we'd like you to keep in mind that we're talking about people going through this system, and we'd like to give you a case example of an imaginary person that would help to frame some of the comments that we're making. So with the next slide, we'd like to describe to you a person named Carl, and I'd like to call on my colleague, Dave Leon, to once again summarize Carl's experience.
Hi, everybody. Thanks, Mark. I just want to introduce myself really briefly. I'm Dave Leon. I'm a licensed clinical social worker. I've been working in mental health for about 25 years, and about 20 of those as a social worker, extensively with people with mental health issues, serious mental illness, and schizophrenia specifically. A lot of my early career was with outpatient mental health at a place called D.D. Hirsch in Culver City. And at that place, I developed a real passion for working with people with psychotic disorders and schizophrenia and other severe mental health issues, and started the Painted Brain, which is an arts organization that gives people opportunities to be together and find shared purpose through the arts, and with the commonality of having a mental health issue or mental health challenge. I'm going to be introducing Carl to us. Carl is a fictional character that we've discussed, who is a 64-year-old man. He is kind of a classic rocker. He's got long hair. He always wears jean jackets. And he has a dog that is very dear to him, a small dog that he keeps on his lap. Carl is fairly reticent to talk about the hallucinations he experiences, but he does have hallucinations of visual and auditory content. But he's more open about having a delusion, which he says in air quotes, "My delusion is that this planet has been infected by aliens from another world that have caused a lot of the problems that we're facing in this world." He knows that people call that a delusion. He believes it very fully, but he's sort of adopted the language of the mental health system that he's a part of. He's a really gentle man generally, but when he gets agitated, he gets more serious and less emotional. He's homeless. He's close to his sister. He has some friends on the street, and his dog is his main support. When his symptoms are more intense, he tends to just sort of buckle down and stay with his dog and try to minimize contact with others. Yes, taking a person-centered approach. Let's think about how to think about the person before we think about the illness or the diagnosis. When you meet somebody new as a supporter, you don't know this person, you don't know how they identify or what they think about themselves. And so it's really important to try to observe this person and think about, what are they trying to show you about themselves? How are they dressed? Do they have special jewelry on? Do they have a special haircut that might be something to comment on? A person-centered approach is really recognizing that a lot of the people that we meet through this role have been through a lot of trauma. And so if the person is very edgy, gets angry easily, or sort of gets agitated easily, it's important to see that through the lens of trauma, that this person might be acting that way because they've been really afraid or hurt in the past. It's important to think about all the different aspects of this person in addition to the fact that they have schizophrenia. So thinking about their mental health and physical health, thinking about the culture and their identity within their own culture, thinking about what their individual strengths are and what they find interesting in the world, identifying goals that they have for themselves. What do they want in their life, as opposed to trying to put that on them? What are their preferences? What kinds of relationships do they have? And as a supporter, we're trying to really take this person-centered approach where we connect with the person and recognize that that person has an illness called schizophrenia, but it's a person first. Thanks.
Dave, I want to jump in, and I appreciate that you're talking about using person-centered language. Carl is a person with schizophrenia. He's not a schizophrenic. He's got a person who's got relationships with his family, with his pet, with others, with his friends, with his community. And so it's really about Carl as the individual with the strengths, with the joys, with the uniqueness that he brings to these relationships. And so it's about really keeping it focused on Carl and the individual. You also mentioned Therapeutic Alliance, and it's referenced on our screen. And I want to just touch quickly on Therapeutic Alliance. That's not just about the doctor relationship. We all have alliances and relationships where we are showing respect and valuing what's important to the other person, considering their preferences, needs, strengths. And so I think as a supporter in this role who's working with an individual and supporting that person through the care process, the idea of the therapeutic alliance, that relationship is just so central. I'm going to pass it back to you, please, to talk about the psychiatric advance directives.
Thanks. Next slide, please. Yeah. My colleague and personal friend, Ellen Sachs, a law professor at USC, wrote a book several decades ago about psychiatric advance directives. And she wrote about it from the perspective of Ulysses from the Odyssey. Ulysses was traveling across the ocean. This is in Homer. And he knew that he would pass through an area with the sirens. The sirens would call to him, and he would steer his boat into the sirens and destroy his people. And so Ellen Sachs used this as a jumping off metaphor to think about psychiatric directives. She talked about self-binding. What Ulysses did was have himself bound to his mast of the ship so that when the sirens called and that madness sort of afflicted him, he would not steer his ship into the rocks and stay on course. And so as a jumping off point, the psychiatric directive is kind of the same recognition. It's a very mature recognition from people that have mental health disorders that are significant, that they recognize that they will have periods in their life where they might not be able to make every decision for themselves. They might be out of control, or they might have psychiatric symptoms that make them sort of lose touch with reality. A psychiatric directive is an opportunity to recognize that that's a feature in somebody's life and work ahead of time to create a legal document that says, this is what I want to happen. If I lose control, if I become extremely psychotic, if I'm not able to make decisions for myself, these are the people that I want involved with my care. These are the medications that help me. These are the medications that I don't like. These are the kinds of treatments that I like. This is how I want decisions made for me when I'm not able to make decisions in the future.
Thank you, Dave. I appreciate being here with you today to talk about this. A little bit about me before I jump into this is I'm Deborah Rose. I'm out of the New York City area, and I'm a licensed clinical psychologist. I've been working in behavioral health care for the last 2 decades. I've had experience in social service agencies, in hospital settings. For a few years, I was deputy director of behavioral health across Rikers Island, where we were the largest servers of behavioral health services in the country at that time. And so working and empowering people who are living with behavioral health conditions is something that is dear to my heart and that I feel passionate about. So I'm just very happy to be part of this important work that we're doing. Moving forward, as we jump into evidence-based practices, I talk a little bit about what does that mean when we say evidence-based. And it really means exactly what it sounds like. It's programs or services, medications, therapies, interventions that are based on evidence. There's been enough research, there's been enough professional review, peer review, doctor to doctor, social worker to social worker, recipient to recipient, about what's important enough to demonstrate that these kinds of interventions are effective. So you'll hear about evidence-based practices, meaning that these are services and approaches that really can impact the individual. And I'm going to talk about a couple of them. I think what's important, and I do want to point out, is that despite being an evidence-based intervention, what works for one person might not work for the next person. We've talked a lot about Carl. What's effective and supports Carl towards empowerment and towards independent living might not work for me. And so this cadre of evidence-based practices put together are really the best that's out there, but they need to be tailored to the person that we're working with. So I think that we're going to jump into a couple of examples, and I'll describe a few of them. The first being illness self-management. And this really refers to the idea that people can and should receive education about their condition. We should be arming people with as much knowledge about what's effective, what doesn't work, what feels right, so that they can learn how to adjust and compensate and begin a journey of recovery for themselves. And part of that journey, meaning the ups, the downs, the periods of successes, the occasional challenges that will come with it. And so illness self-management, really, you'll hear it called psychoeducation. We're educating people about behavioral health, the conditions, is a way of teaching and empowering people with information at their pace, in their language that works for them to support the individual over their recovery. Another kind of education that we talk about is family-based psychoeducation, and that's very similar. It's providing families, and by family, I want to emphasize it's not just a birth family or genetic family. It's the family that is the chosen support for an individual, and their circle of support. And so it's providing families with education, information, arming them with whatever's needed to help support an individual that they care about. So I'll be able to refer you to an upcoming training on this where you can have more information if you're interested. And I hope that you do take a moment to look at that training. Social skills training and cognitive behavioral therapy. I'll say it again, cognitive behavioral therapy, CBT. I wanted to repeat it because it's approach for both thinking and behaviors. How do we help somebody learn the skills to talk through, to check themselves? If I'm experiencing this emotion, here's a way that I can react. Here's another alternative to how I can react to it. And so through social skills training and through CBT, it's really helping individuals learn to improve self-care, improve relationships, improve their behavior, all to succeed independently and with relationships in the community. As we know, and we've talked about in our earlier presentation, people who are living with schizophrenia are also at higher risk for substance and alcohol abuse disorder. Sometimes that's about self-medicating to treat some of the symptoms. And so it's important that we offer, when it's appropriate, psychosocial interventions for alcohol or substance use disorder. And this can come in a number of different forms. There could be support through talk therapy, through mentorship, through peer recovery supports. Peers, other people who have lived experience are an essential component to somebody's journey of recovery. And so there's a ton of evidence-based information that's available about interventions for alcohol and substance use disorder. Briefly, I'd like to talk about supported employment. One aspect of recovery for folks that we work with, for all of us, is about feeling purposeful. And that sense of purpose might come in the form of employment or volunteer work. And so supportive employment is one type of evidence-based service that we help people learn job skills, soft skills. How do you make a resume? How do you interview? What clothes do you wear for an interview? What kind of supports might be in place that can help a person to obtain and maintain a job, to become more financially self-sufficient, and to feel a greater sense of purpose. So that's another kind of evidence-based program, another evidence-based intervention that's out there. As we've talked about earlier, also folks who are living with schizophrenia or other schizophrenic spectrum disorders are at higher risk for multiple medical complications, including diabetes, high blood pressure, obesity. And there's a significant amount of research out there that offering interventions for weight management is really successful to help folks prevent some of those complications. The last one that I want to mention is assertive community treatment, or ACT, A-C-T, and sometimes you'll hear it referred to as PACT. Maybe we can go on to the next slide and talk about that directly. Thank you. So assertive community treatment, or ACT, again, sometimes it's referred to as PACT, psychiatric assertive community treatment, is one of the most effective evidence-based programs that are out there. It's really about a mobile team, almost like a clinic on wheels, of multidisciplinary professionals, a doctor, a nurse, a social worker, a peer with lived experience, and maybe a benefits specialist and a family specialist. And this team wraps themselves around the individual. So it's not about where the person is living or receiving care. It's works with that individual to support the person regardless of where they're living. Perhaps somebody is street homeless, or is moving into supportive housing, or is staying with a friend. That ACT team, it works with a small census, a small group of people, to really ensure very comprehensive, intensive, ongoing, proactive, supportive care in the community. And so the idea of the ACT team is to meet the person wherever they're at, both physically, but also emotionally, where they're at, to engage that person who maybe has rejected traditional treatment before, who maybe isn't going to a clinic or to a physician, but is willing to work on the street with a peer recovery person as part of this mobile program. And so ACT services are a wonderful opportunity and a service that's available to people. It might look different from community to community. What you see may be a little different than what I'm seeing in my community. But really, all of the evidence for these ACT teams suggests that people who are receiving and engaged in ACT services have reduced hospitalizations, have reductions in some of the symptoms, are able to be housed and sustain housing with more quality, and have general better quality of life and relationships. We have included a link on the slide if you're interested in learning more about ACT, and I hope you take a moment to do so.
Thanks, Deborah. I think Carl is a really interesting person to think through this lens. Deborah was mentioning that the set of different interventions or options for each person is really unique to that person. And Carl is a great example of that. Carl is very ethics bound around his sort of use of his time and his work. And so if he's going to go into supported work environments, it needs to be something where he knows that he's doing good for other people in a very direct way. And otherwise he feels like it's not really fitting his philosophical sort of beliefs about himself or the world. He is very resistant to substance abuse treatment, feels that he has his alcohol use under control and uses it to manage his symptoms when they're out of sorts or more intense. And he is very committed to that sort of as his sort of personal life choice. And he is also very interested in family counseling and family support. He's close to his older sister. And a lot of times when he's making bigger decisions about his psychiatric care or future treatment or planning or psychiatric advance directives, he'll involve his older sister in that decision. So I think the takeaway is to really see that for each individual person, having hope, having ideas, and having sort of options is really a key in the supporter role, but also not being tied into any one specific outcome or goal for that person. It's really based on that person's needs and individual use and interests. Thanks, Mark. Thanks, Deborah.
Excellent. Thanks, Dave. And I'd also like to comment that we've covered a number of evidence-based practices so far today, but that's certainly not a complete list. There are other evidence-based practices out there, and more are developed as time goes on and as more research is done. So you may hear of other evidence-based practices as well. But we're going to pivot now to another important evidence-based practice in schizophrenia spectrum conditions, and that's the use of medications, and specifically antipsychotic medications. Antipsychotic medications are usually prescribed to persons with schizophrenia spectrum conditions, and are very important, very often very important in offering people the opportunity to get relief from a number of their symptoms, and oftentimes making it possible for them to make gains in other aspects of their recovery and services as well. A person with schizophrenia spectrum condition might be prescribed multiple medications, even multiple psychiatric medications. So it can sometimes be confusing to the outside viewer about, what's the purpose of all these medications? So psychiatric medications are clumped into different classes, and each of those are for different purposes. And the class of medications that are used to treat psychotic symptoms of schizophrenia are referred to as antipsychotic medications. And even once the decision has been made to recommend an antipsychotic medication, you should know that there's over a dozen of those medications out there that are available. Some are prescribed more than others, and that there's a lot of flexibility and, opportunity to, customize the treatment plan for any one person. The main goal of the antipsychotic medication, as I mentioned, is to reduce the active symptoms of psychosis, but they're also utilized to maintain remission from psychosis. So you might prescribe it during a hospital stay or an acute episode, but then those medications are continued over time. In general, these medications are most effective at treating the symptoms such as hallucinations, delusions, and disorganized thinking that a person may face. Some of the other symptoms of schizophrenia may be less responsive to these medications. And it's important and although antipsychotic medications are an important evidence-based practice for schizophrenia, it's important to keep in mind that every person reacts to medications differently. And even those people who take medication, they may continue to experience some of their symptoms, even though they're taking medication. It's important to support people through that and be helpful. And finally, of course, like all medications, antipsychotic medications may have side effects, and the list of side effects for antipsychotic medications, the potential side effects, is really quite long, and they include weight gain, worsening diabetes, sleepiness, neurologic symptoms. Not everybody has any one of them, but any one person could actually have more than one side effect, of course. And Deborah Rose mentioned the evidence-based practice of psychoeducation as one of the evidence-based practices. Educating patients about medications and their potential for side effects is an important part of that psychoeducation. Let's go on to the next slide. And so medications are mentioned in the CARE Act description, and so medications may be part of the CARE Act plan, and that CARE Act actually references the term medically necessary stabilization medication. And those can be a component of the care plan and may actually be court ordered in the care plan itself. That usually arises out of the completion of a clinical evaluation and then the CARE Act hearing. And that happens when the court has determined if the individual has the ability to have capacity to make decisions, and then that can also lead on to the ability to obtain informed consent. The definitions for each of those terms are included here in the slide, and I refer you to that. But I do want to mention here that as part of this CARE Act proceedings and the care plan, even if medications are in the care plan, there's also language in the care plan that says that medications shall not be forcibly administered as part of the CARE Act or care plan. There are, possible scenarios outside of the CARE Act, such as if the patient was involuntarily detained under what's known as the 5150 or 5250 laws in California, where medications are sometimes administered against patient consent, but that is not the case here in the CARE Act. And with that, I'd like to move on to the next slide, please. So what's the role of the supporter for the person going through care act proceeding is, really everybody that is touches a person that is experiencing schizophrenia can have a role in helping the patient with medication adherence. So once the decision has been made for a person to take medication, of course, these medications are typically administered in a regular way, and they work best when the patient takes them. If it's in a pill form, that's usually daily, and if it's in a injection medication, there's still a periodic frequency that you want that to happen regularly. And so we want the person to take that medication regularly, and that's known as medication adherence. And so the ongoing use of these medications can be very important in maintaining clinical stability, including, for instance, staying out of a psychiatric hospital. But research suggests that adherence to antipsychotic medication can be challenging. Frankly, adherence to any medication that any of us take can be challenging. But even more so in persons with schizophrenia spectrum conditions. Up to half of persons who take antipsychotic medication fail to take them regularly, especially after acute events, such as after a psychiatric hospitalization. That's the why, and the how is how to promote medication adherence is one particular challenge of the pill form of antipsychotic medications is the need to take it every single day. And this, of course, that takes a fair amount of determination, preparation, regular routine. And these are all challenging in persons with schizophrenia for reasons that we've already covered so far in this series. There is an option for persons for what's called a long-acting injectable antipsychotic medications, sometimes abbreviated LAIA. For individuals who choose this options, injection medications are done much less frequently, of course, than pills, which are daily. Injectable medications are anywhere from every 2 weeks or to as long as once every 3 months. So the decision whether or not to use a long-acting injectable medication is just like any other medication decision and should be made in partnership between the provider, the person, and their support system. And this is particularly true because transitioning to pills to the long-acting injectable medication kind of needs a careful attention. There's sort of a titration between one and the other, and you need to make sure that kind of goes right. And so that's the why and how side of things. And I'd like to hand the mic to my colleague again, Dave Leon, to talk a little bit about a bit of the, what can be done to support medication adherence. So Dave, I hand it to you.
Yeah. Thank you, Mark. Thanks. I appreciate it. I try to think from the supporter role that we're all trying to learn how to sort of embody in ourselves as we take this training. As a supporter, you might still have some pretty strong beliefs that people need to be on medication or that what's prescribed by the psychiatrist needs to be adhered to. But I think it's really important to try to withhold judgment and really think in a person's first method to think about what the person that you're supporting really needs and feels about their medication. As Mark mentioned, there's a lot of complications around medications and a lot of side effects. And if you think about your own sort of mental health or medical history, how many times have you sort of exactly followed what the doctor said to do? So I think it's really important to withhold judgment, listen, be open-minded, and talk about the options and treatment sort of benefits and challenges of medication, and really listen to the person talking about what their thoughts and experiences with medication have been. Often the supporter is helping to see sort of how that person might talk to their treatment team differently, suggesting ideas. And with an example of that, I'm going to pass the mic over to Deborah, who has an example of sort of a quick fix situation for somebody that had a medication challenge. Deborah, could you?
No, thank you, Dave. Yeah, it was about asking questions and listening. and withholding judgment and moving away from this person is non-adherent, this person is labeled non-compliance. And once that happens, you just can't get past it. I remember a few years ago working with a young man, a young adult, who was deemed non-adherent to medication because he was not taking his evening medications. He lived in a group home where he was supported by a team of professionals and peers, and he didn't take evening meds. A meeting was called, it became an urgent issue, and everyone is brought to the table. Turned out this young man, at the time that the meds were given, he wanted to go out with his friends. It was 8 o'clock at night. He wanted to hang out and go to the movies or have dinner or socialize. All we needed to do was ask the right questions and listen. And suddenly, by being flexible and saying, well, we can offer meds earlier or later, made all the difference. So to your point and to Mark's point about withholding judgment from the outside perspective looking in, trying to take a moment to understand what matters to the person and maybe what some of the issues and challenges are about medication. Thank you.
All those are really amazing points. So thanks to both of you, Deborah and Dave. And really, us doctors talk a lot about the art of prescribing medication, and some of those considerations I think are part of that. And I can remember a person I worked with once upon 10 years ago or so that, after we worked for a while and she was very stable on her medications, she made the decision to try to use the lowest possible dose of a medication, knowing that she'd have some hallucinations at this lower dose. But that also, reduced her risk of side effects as well. So it was a really great lesson for me and an example of a person who was able to really, take a real, decision-making role and self-management role for herself, which was really empowering to her and was a really positive experience, I think, overall, for her in managing her overall illness. I'd like to move to the next slide. This is the last of our content slides for this module. And I want to touch again on the subject of is that, oftentimes people with schizophrenia take more than just one medication. And why is that? And there's a number of reasons why that would be. So persons living with schizophrenia spectrum conditions oftentimes have other things that we have to deal with medications. So sometimes they have other psychiatric conditions, such as depression or bipolar disorder, and those conditions might need a different medication for that. Sometimes additional medications are needed to treat the symptoms of depression that the antipsychotic medication didn't help with. For instance, maybe they're having difficulty sleeping, and we want to address that with a different medication that might be more specific to that symptom. People with who are taking antipsychotic medications sometimes have side effects to those medications, as we mentioned, and there are medications that oftentimes treat those side effects. So that's yet another category of medications. And then finally, just like the rest of us, persons with schizophrenia might have other medical conditions. I don't know, blood pressure, high blood pressure, something like that, and they might have to take medications for that. So that's why people with schizophrenia may ultimately end up taking more than just an antipsychotic medication for their condition. Of course, the ultimate goal is for us to use as little medication as possible in any one person, while also safely and effectively treating their condition. Okay, that is the content for this module. Let's move on to summarizing and looking at what did we talk about in this section. So in this presentation, we defined and discussed a number of evidence-based practices and approaches for persons with schizophrenia spectrum condition. The main takeaways that we hope that you take with you are that no matter what evidence-based practice we choose and whatever medication is recommended, that we take a person-centered approach with all of our interactions with a person. Wraparound services such as the ACT or PACT model can be particularly effective, and antipsychotic medications also are important and should be approached in collaboration with the person and their family and other supporters, without placing judgment on their needs, preferences, and without placing judgment on their pattern of adherence. And with that, let's move on to our last slide, our ideas and action slide. And Dave, I wonder if you could take the lead in pulling this together for us.
Thanks, Mark. I will certainly try to do that. I think that Carl is an interesting person to refer back to in the context of all this. Carl has a number of different psychiatric symptoms and symptoms related to schizophrenia, as we mentioned. He has delusions about sort of alien invasion of the earth, and that a lot of the badness that we see in interpersonal communication and systems is actually due to this alien sort of invasion. And he also has hallucinations that are troubling to him, voices and visions. He decided long ago that a regular injection of a medication is a lot easier and makes more sense for him than a daily medication. And he takes the medication because it lowers the intensity of the hallucinations. The belief system that he has around his delusion doesn't seem to be too impacted by his medication, but he really doesn't like hearing voices or visions. And so he's decided, with a lot of support from his sister and other care providers, that medication is helpful to him and he wants to be on it to minimize those unwanted symptoms. Carl is also, kind of choosy about how he spends his time. He's very interested in psychoeducation and family-based services, less interested in substance abuse-oriented services. He is actually quite open to supported employment, but only if it's in the role of taking care of other people or doing something that's actively providing good in some way. He's a very philosophically driven person. He's not so open to talking about weight management and other sorts of medical issues that he's facing. And I think that's an area that the supporter could continue to try to engage with and be curious about and think about what might allow him to take his medical challenges a little bit more seriously. And so far, he's not needed to be a part of assertive community treatment because he's pretty, as they say, treatment compliant. He's found ways to sort of get what he needs out of the mental health system and make it work for him at some level. And the supporter has a great chance to just the options open and sort of keep in touch with Carl as he moves forward with his journey. I hope that's pulled it together. Thank you all for listening, and let me pass it back to Deborah or Mark to close into a closing comment or two.
I just want to say thank you and ask that folks join us in our third part of this series. We look forward to seeing you there. I'm going to ask Patricia if you can go over the objectives that we covered today, please.
Yeah, thanks everyone. And hopefully you're coming away from this discussion with a sense of optimism and seeing the different options that are available. As Mark mentioned, we shared some aspects of evidence-based practices. There are more out there. There are more promising approaches that individuals are taking to better manage and recover from serious mental illness. So at the end of this session, it is our goal that you will have an increased ability to describe those principles of taking a person-centered approach that we talked about earlier, and using person-first language and recognizing, like Dave mentioned, that they have a diagnosis with schizophrenia, but there is much more to that individual in their holistic needs, preferences, strengths, and their goals. And then we talked through some of those evidence-based practices. And hopefully you have a better idea of those different practices that are available in treatment, and then have a better understanding of the role of medication, not only in their treatment plan, but about the role of medication in the CARE Act, and how medication will be handled throughout the care process. Some next steps for you. There's a lot of resources that you can turn to on the CARE Act website, both for implementation teams and for volunteer supporters as well. And then another next step is to view the other trainings in this series. If you haven't already, part 1 is Schizophrenia Basics, provides some explanation about features and symptoms and some other information that could be helpful. This is part 2 in that series. And then part 3, supporting persons with schizophrenia, and some ideas on how supporters, family members, peers, friends can help support individuals with schizophrenia. So thank you for joining, and we'll see you in the next training.